Hey everybody, welcome back to the ECG of the day. My name is Reed. Before we get started, you know the drill. Go ahead and head down to the description and you can download the PDF of this exact ECG here, this template, so that you can follow along and make your own notes, save it for your studies later. And if you'd like, please subscribe to the channel. I love the support so we can keep doing these videos. So let's go and get started. So the first thing I like to do is just look at the forest and really just get a gist of the ECG here. And the trees of the forest are my QRS. So maybe I'll pick like lead 2 here and I'll see I've got this regular rhythm here. It's a narrow QRS. It seems to stay pretty regular throughout the entirety of the strip. Small deviations that really aren't too terribly concerning. What I'll do is I'll find a QRS here. Maybe we'll pick this one and we'll count off and see what the rate is. We got 300, 150, 100, 75, 60, 50. So maybe 42 or so beats per minute. So we've got a severe bradycardia. This is a bradycardia because it is less than 60 beats per minute. And so start to kind of work through, well, what's my differential for bradycardias? And when we do that, we just take a quick glance and see we've got some P waves before our QRSs, and so that's a bit reassuring. And so next thing I'll do is I'll just go ahead and straight head into my atrial activity. You know, we kind of go down the conduction pathway, and the first thing it's going to depolarize is the atria. And so I look and I see I've got some P waves. My P waves appear to be upright in lead 1, and they appear to be upright in AVF. So that tells me that they're heading down and to the left, which is what we usually see in atrial depolarization. And so that is a sinus P wave. And so I'm starting to kind of work through, is this bradycardia just a sinus bradycardia? Is there any AV blocks? And that's what we're going to head into next, is what is our PR interval? Our PR interval is measuring our AV node function. And so I see here, if I measure my PR interval, maybe right on this beat in lead 2, you can see that my PR is less than 200 milliseconds, and it's a normal PR interval, so that's reassuring. I want to scan through and make sure that all the PR intervals throughout the strip are the same, and you can see, if I just kind of tick away at these PR intervals, they all appear to be about the same until maybe that one's a little bit off, actually. And so that might make you think, well, why did the PR interval for this beat actually shorten, right? So this is a shorter PR interval. So that might make you think, well, I wonder what's going on with this rhythm. And so is that the case always here? And so what you might notice is that as we scan through, that this PR interval seems to be a little longer, this seems to be a little shorter, then it's kind of intermediate in the middle as well, and then it gets longer again. But what we don't see is we don't see any P waves that are occurring without a QRS, so it's not like we have a bunch of P waves that are not conducting. It seems like there is some dissociation between the atria and the ventricles, right? Because we should see an AV node that is conducting in the same fashion. And so let's take a look and see if there is any kind of pattern to this. And so what I'm noticing is that there's likely some sinus arrhythmia. We know that sinus arrhythmia is due to inspiratory and expiratory changes in cardiac filling and preload. And so we can see the rate of atrial activity increase and decrease. And in the setting of a severe bradycardia, what we might be seeing are because it's such a slow rhythm, we might be seeing some junctional escape beats. And so the QRSs that are actually conducted with short PR intervals, which would be this one, and this one, and maybe even this one, it's kind of questionable. These ones that are shorter PR intervals, there's actually a chance that this QRS is a junctional escape. Because we know that the AV junction, right around here, has the ability to create its own signal that fires off and depolarizes the ventricles in a normal fashion down the His-Purkinje system in about a rate of 40 to 60 beats per minute. And so what we might be seeing here is because we have such a significant bradycardia at 42 beats per minute, when that sinus rhythm dips down a little bit less, we see that these junctional escapes occur right before that P wave would conduct to our QRS. So that junctional escape is occurring right before that P wave would conduct to the QRS. And so what's happening is that sinus P wave is essentially getting to the AV node, but before then we've got a junctional escape. So we've got junctional escapes as well as normal sinus beats, right? I would say this is a sinus beat, this is a sinus beat, right? So we have kind of intermittent junctional escapes here with slowing of the sinus node. That's normal. That's a normal response by this heart. All right, so we talked about that. Let's talk about our QRS. Our QRS is narrow. It is upright in lead 1. Seems to be kind of isoelectric here in AVF. So that tells me that it's going towards lead 1 and perpendicular to AVF. So my QRS axis is probably straight towards lead 1 at 0 degrees. And so that's okay. That's normal. We've got what it looks to be poor R wave progression. I don't see many good R waves throughout my precordium until I get to maybe V5 and V6. So we've got poor R wave progression and throughout the kind of precordial lead. So poor R wave progression, right? And what is R wave progression? Let's just kind of review that real quick. If I look at my transverse view of the myocardium, what you'll see is that the left ventricle, which is this big bulky ventricle on this side of the heart, is a lot bigger than the right ventricle. And so as we're transitioning from V1 all the way through to V6, we should see the R wave growing. Our positive forces should be growing as we start capturing more of left ventricular depolarization throughout our chest leads. And so that's why we look at kind of the R wave progression. But we've got poor R wave progression here. We'll try to explain that in a little bit. Last thing we'll do for this part is look at our QT interval, and you can see that the QT interval is, definitely appropriate. So I'd say we've got a normal QT. And so now let's look for our ischemic changes, our pathological Qs and ST changes. And what you've probably noticed this entire video and what we've been waiting for is we see some significant ST elevations. And with the most predominant ST elevations, as you can tell, are right here in V4. If I draw my baseline and my ST, very significant. Same thing with V3. And then here we have also got a bit in V2 all the way up to V1. It starts to kind of decrease as we get a little bit more to the lateral leads. You can see V6, there's really not so much ST changes. Our lateral leads appear to be kind of not significantly elevated. And same thing with our inferior leads. Maybe a hair of elevation, but not much. We see a little bit of depression here in AVL. We've got ST depression in AVL. And so let's talk about what's the distribution of this infarction. Well, the most predominant leads are probably V5, V4, V3. And we know that, really with V4 kind of being the center of gravity of this ST segment elevation, these are the anterior leads. And we said we've got some septal involvement, V1 and V2, which are our septal leads. So anterior leads are V3, V4, septal leads are V1, V2. And so I would say there's probably some anteroseptal ST segment elevation. So anteroseptal ST elevation, as well as ST depression in the lateral leads, really AVL. And so that's really significant for myocardial infarction in the right clinical setting, really in any clinical setting. And you can already see we've got these pathological Q waves that are developing in these leads, telling me that we need to probably intervene on this pretty soon because there's already some myocardium that has completed the infarction. Probably the most deep endocardium has already completed the infarction. And so, what artery supplies this, right? And we kind of think, why do we need to have a certain anatomical distribution? Well, a myocardial infarction is an occlusion of one of the coronary arteries. And so we know that the left anterior descending, or the LAD for short, is what supplies the anterior aspect, most of the anterior aspect of the left ventricle, as well as some of the septum. So the LAD supplies probably 1/2 of the left ventricle, of the left ventricular myocardium. Like I said, some of the septum. And so, yeah, this would be a left anterior descending artery occlusion. So, all right, let's do what we need to do and put this ECG together. So what do we have? We've got a sinus bradycardia at a rate of 42 beats per minute. We said we had some junctional escape rhythms. We would call this intermittent junctional escape rhythms with slowing of our sinus bradycardia. We've got poor R wave progression through the precordial leads, V1 through V6, which is best explained by this ST segment elevation that we see in the anterior septal leads, V1 through V5, with some reciprocal depression, ST depression in AVL. So, hope this helps for you all. And this was definitely a tricky one with a little bit of kind of the weird PR interval changes that we need to explain. And this severe bradycardia, this person probably has a pretty damaged myocardium. So, hope this helps you all. And if you have any questions, throw it in the comments. Have a great day.